So first up, we will have Dustin Staloch, one of our PGY2 residents. He'll be presenting the case to Dr. Del Rio. And so Dustin is a Texan, born and bred. He got his bachelor's in biology from Southwestern University in Georgetown, Texas. He then honed his bench skills at Texas A&M and then went to medical school at UT Houston. So without further ado, Dustin, it's all yours.
Absolutely, thank you. Thank you, everyone, for joining us. I'm going to leave as much time to our discussant, so let's jump right in. Our patient's a 39-year-old woman with a history of obesity, status post-gastric bypass, with a very complicated post-op course, which unfortunately has left her TPN-dependent. She presents to a pulmonology clinic for shortness of breath with exertion over the past year. So as an outpatient, she follows up with nutrition and general surgery, where she presented with these complaints initially, prompting a chest x-ray which showed bilateral lower lobe consolidations. They followed this up with a CT of her chest, which showed numerous pulmonary nodules, prompting a referral to us in pulmonary clinic. When she saw us in clinic, she said she felt overall well, but did note increasing shortness of breath on exertion over the past year, specifically with stairs and inclines. On direct questioning, though, she denied any other pulmonary symptoms of coughing, wheezing, or hemoptysis, denied any constitutional symptoms, and denied orthopnea, P&D, or lower extremity edema. Digging through her medical and surgical history is significant for in 2003, because of her obesity, she underwent a Roux-en-Y gastric bypass. Unfortunately, things got more complicated after 2006 when she presented with sepsis, secondary to a Peterson's hernia, which had caused small bowel necrosis. This led to the resection of the better part of her small bowel and left her with short gut syndrome. Because of this, she's been TPN-dependent for the last 10 years and has suffered recurrent bloodstream infections, including Staph aureus, serratia, and Candida. She's also suffered a catheter-associated DVT and is left with chronic reflux symptoms and opiate dependence. In terms of other history, she's an Atlanta resident. She's married with 2 kids here. Before all of this happened, she was a med-surg nurse, but since retired. And she directly denies any occupational exposures, directly denies tobacco use, any alcohol use, or illicit drug use. She says she hasn't had any recent travel and doesn't have any outdoor hobbies, and the family doesn't own any pets or a hot tub. In terms of family history, it's significant for a maternal grandmother who had lung cancer, but otherwise everyone's alive and well without infectious or autoimmune conditions. Digging through her review of systems, again, she's got no fevers, weight loss, fatigue. She does note exertional dyspnea without other pulmonary complaints, and reflux and diarrhea, which are chronic and stable for her over the last several years without other GI complaints. Otherwise, essentially pan-negative, no joint symptoms, no neurologic symptoms, no swollen lymph nodes, rashes. In terms of medications, she's been sporadically prescribed acetaminophen, oxycodone. Someone at one point prescribed her albuterol for these symptoms, but otherwise she's on TPN and medicines that address her reflux, diarrhea, nausea, and vomiting. When she saw us in clinic, she looked overall well. She was well-appearing, well-nourished. She was afebrile, hemodynamically with normal. She was breathing 14 times a minute and satting well on room air. Her lung exam was totally clear. There was a port in the right side of her chest that looked healthy. And in terms of her CV and abdominal exam, benign, no joint swelling, no rashes, no clubbing. She was neurologically intact. So as we usually do, we got some basic labs, which were largely unremarkable in terms of electrolyte disturbances or LFT issues, aside from her hypoalbuminemia. CBC revealed a white count of 4,000 with the differential as presented here on the screen. She's mildly anemic at 11.2, but with an NCV of 89 and a ferritin of 55. She's HIV negative, and at that time we ordered an ANA and rheumatoid factor, which ultimately came back to ANA negative and the rheumatoid factor a little elevated at 68. Some pulmonary function tests were completed. I'll let our discussants talk about them in more detail, but essentially her spirometry is normal. the lung volumes are normal. And down here, you can see her DLCO is decreased at 56% of predicted. This is the chest x-ray that was obtained and read as bilateral lower lobe consolidations. I think maybe that's a conservative read. I think as you can appreciate, the better part of her lung is involved with pulmonary nodules, which, as you can appreciate on the CT scan, really don't spare any part of the lung, don't really tend to cluster in one specific dense consolidation, really kind of everywhere. But I think on this cross-section, you can appreciate that these innumerable sub-centimeter pulmonary nodules have a predilection for the middle and lower zones, sparing the apices a little bit more. So at this point, more diagnostic tests were performed, but I think before we move on, let's give the audience a chance to kind of weigh in on what's affecting Our Lady. So again, you can weigh in online at pollev.com or text in. And then they pop in up on the screen like this. This is wonderful. I think that looks good. So it looks like TB right now is winning. So maybe that's the question of the day. But I see a lot of stuff addressing fungal infections of the lung, kind of atypical lung infections. Some other stuff floating around there. So I think at this time, I had the pleasure of introducing someone who actually doesn't need an introduction, but is going to get one anyway. We've had the pleasure of having him here with our on faculty since he completed his medicine and infectious disease fellowship here at Emory. He's the Hubert Professor and Chair of the Department of Global Health at the Rollins School of Public Health, and is Professor of Medicine in the Division of Infectious Disease here, with particular interest and expertise in HIV/AIDS. Dr. Del Rio, I'm interested to see what you got.
Thanks, Dustin. Well, thank you, everybody. It's always fun to do one of these CPCs, and again, as Dan did last time, I want to first of all congratulate Jeff and the committee, because they kept me on the dark. I mean, they would not let me know who the discussants were, who was coming, what was going on, and they did a really good job of putting the case together. So I want to look first at some of the pertinent highlights from the case, and I'm a big Sherlock Holmes fan, and I think that I love this quote that the world is full of obvious things which nobody by any chance ever observes. And I think a lot of what we do here is really observation, is really look at things and try to review them with a careful eye, with a different eye. And I always tell house staff and residents, don't let other people tell you what they think. You need to do it yourself, because that's how you find things. So let's look at the PFTs that Dustin showed us. And what you see are a couple things. You see a borderline reduction in airflow. You see normal lung volumes. And you see a reduced diffusion, which is right here. The diffusion capacity is markedly reduced without a hemoglobin correlation. And I'm not a pulmonologist, so I actually called one of my pulmonologist friends and said, okay, help me interpret this. And the labs were very unremarkable. I mean, there was no leukocytosis, no lymphopenia, no eosinophilia, anormocytic anemia, low albumin, and elevated rheumatoid factor. So very, very unremarkable labs in such a remarkable case, which really, where we all go is in the image. And I think all of you, just like me, when I first saw the case, I look at the CT and the chest X-ray and I said, wow, this is pretty impressive. And a couple of things strike you. I mean, there's diffuse pulmonary nodules with a central lobular distribution. And what there appears to be also, if you look at this reconstruction, even though it spares the upper lobes, there appears to be a cavity here. And if you look at that lesion here, it looks like it's cavitated, and there may be others. We just have this one section, but there may be others that show cavity. So there appears to be some cavitation of them. They are all over the place. They're not necessarily just plural-based, and you can see their distribution. Again, I'd like to do a problem. This list is a good way to sort of gather your thoughts, put everything together, try to see in which direction you're going. And I'm not going to, go over the problem list again, but one of the goals is hopefully to try to tie all these things together. How do you tie everything that you see in this problem list? How does this all come together? And we, of course, they got somebody from ID to do this, and we, of course, in ID like to ask a lot of questions. That's what we do, and we like to know things that necessarily were not presented here, and I may ask Dustin that, but where is she from? I mean, is she a native of Atlanta, or is she from some other place? Could she come from a Coxie endemic? Is this native from Arizona? What do we know about this lady's background? Where is she from?
She's Georgia native.
So Georgia native. And where has she gone recently? Has she traveled? She has any travel history?
Not since they've had a kid, they haven't traveled.
Okay, so no travel history. You told us that she is a retired nurse with no specific exposures, right? And you told us she doesn't have a hot tub, which is something that I immediately thought about. Could this be hot tub lung? But does she go into caves, for example, at some point in time? Does she like to go into caves? And you say she doesn't. And again, you said she doesn't have any pets. And she was tested for HIV. You gave us that result. And she's opioid dependent, but does she inject any drugs? Does she do any drug use? And you said no. So those are important questions to ask your patients when you're seeing any case. So at this point in time, I'd like to move to think about a differential diagnosis and come with a diagnostic rationale for what's going on. And when I think about approaching this case, one thing you can do is to focus on what's most significant. And in her case is those pulmonary nodules, right? That's where I would like to start my discussion and my differential. But then I'm going to take you back and really think about the case holistically, go back to that problem list and say, yeah, but how does that fit with everything else we know in this patient? And I think that's important to do because, again, it's a capital mistake to theorize before one has data. And this is what you guys did right now because I did the same thing. You start immediately to twist the facts to fit your theories instead of the theories to suit your facts. And that's what we all did. I looked at this and I said, this is TB or this is atypical mycobacteria, exactly what you had up on the board. And I think you were missing some facts when you did that, and we all make exactly the same mistake when we get pulled into something so significant. So, when you think about the differential diagnosis of pulmonary nodules, and again, I apologize for David Godot. I'm not a practicing pulmonologist, so I'm just going out of the literature, but I get to see this X-rays. I think malignant is one thing you think about. I would tell you I don't think this is malignant because I don't think the residents will be as malignant enough to invite me to discuss a lung cancer case. But, it has happened to me at COCO conference that I've had things like this, so I have to at least think about the possibility of this being malignant. Multiple pulmonary nodules are malignant tend to be over a centimeter in diameters. And you usually tend to have a solid tumor somewhere that is causing this. Some of them tend to hemorrhage, choriocarcinoma, renal cell, melanoma. And others tend to have sort of displayed a halo-like appearance. Benign nodules tend to be smaller in diameter, and they frequently are juxtaposed to either the visceral pleura or the interlobar fissures. And they frequently, like in this case, are detected incidentally. And when that is the case, there frequently are benign lesions, such as granuloma, scars, or interpulmonary lymph nodes. So I think in this case, I'm starting to say, well, this is an incidental finding. This lady's fairly asymptomatic. She's, say, febrile. She's got this nodules. There's got to be something benign. So you went through the differential. You had it up on the screen. This is sort of the quick and dirty benign pulmonary nodules differential diagnosis. And you did the exact same thing. Interesting that when you listed your differential, none of you put malignancy there. And again, you figured that I was discussing, so it couldn't be a lung cancer. But I want to be sure that you think about lung cancer when you're seeing something like this. But the differential diagnosis of benign lesions like this one would be TB or non-tuberculous mycobacteria. Bacterial infections, including septic emboli from infected endocarditis. This lady has a long history of bloodstream infections secondary to her line. We didn't hear a murmur, but she could easily have a vegetation in her tricuspid valve or a vegetation in her line, and she could be throwing emboli. So I think that needs to be considered. But I would expect her to be sicker. I would expect her to have a fever. I would expect her to have other findings. And fungal, aspergillus, you didn't tell us here, I think, but at least in what you sent me, you said the galactomannan was negative. And histo would be something to consider. And again, histo is possible, but I would hope that with that last CPC that Dan Hunt did was histo, so I hope they don't do histo twice, but again, it could happen, so I'm going to drop histo a little lower just based on that fact. Non-infectious, I mean, this could be nodular sarcoid, this could be silicosis, this could be amyloid, this could be granulomatosis with polyangiitis, right? So, you know, I found this paper in Chest that looks at how you work up pulmonary nodules, and, you know, these are central lobular nodules, these are primarily in the bronchial distribution. So again, it takes you exactly to where we were. This is either, you know, TB, MAC, bacterial infection, fungal, or a couple other things down here. And if they're pulmonary nodules like this, they're likely granulomas. So I went to the literature and looked at what causes pulmonary granulomas. What are the causes of pulmonary granulomas? And, you know, top of the list, of course, are your mycobacterial infections and then the fungal infections we talked about. So I was ready to say this is TB or MAC. I don't think this is fungal because, in my experience, people that have fungal infections like this, again, tend to be fairly symptomatic. But you can have people with TB who are, especially with disseminated TB, who tend to be asymptomatic, or atypical mycobacterial infections who can be asymptomatic. And if she's from South Georgia, could she have MAC in her lungs? It's a possibility. I mean, she has multiple central lobular nodules on CT scan. They're likely infectious. They're more likely granulomas. So there's probably are mycobacterial and fungal. Yet, I really didn't think this was either mycobacterial or fungal infection. And I didn't think so because there were other things that just didn't fit. You know, why does she have a rheumatoid factor that is positive? Does she have rheumatoid nodules? Could this be silicosis? She got exposure at home. Could this be pneumoconiosis? What do we know more about her exposures? We need to ask her about her life, what she did before. I just remind you of something called Kaplan's disease, a combination of rheumatoid arthritis and co-workers pneumoconiosis that manifests itself with multiple pulmonary nodules. So the question is, what do you do then? I mean, you could say this is TB or MAC, stop, or this is fungal infection, stop. Or you can do, which is to go back to the patient and to think about it again and to try to say, how can we fit all this together? And at that point in time, I realized that I had come to the entirely wrong conclusion. And in fact, what I had done is I had made a decision with insufficient data, and I had made a wrong conclusion based on the data that I had to this point. So I went back to the patient and thought about it a little more and said, you know, she's a retired nurse. She describes a chronic illness with shortness of breath with exertion intermittently over the past year. She doesn't describe a fever, weight loss, other things that I would expect if she had an infection. She has the central line for TPN. She's opioid dependent. Her PFT showed reduction in diffusion reduction with normal mechanics, and this is about 70% specific and sensitive in the literature for what is called pulmonary vascular problems like embolic phenomena. And the location of their nodules suggests hematogenous dissemination. So I put all of that together, and I said, well, you know, once you excluded everything, whatever is left, however impossible, must be the case. And we heard over and over here, and Dustin just repeated, she adamantly denies injecting drugs. Well, I think that's wrong. I actually think this lady is injecting drugs. And I think this lady has excipient lung disease, which is also called injection granulomatosis or pulmonary foreign body granulomatosis, which is secondary to IV injection of crushed opioid tablets. And I suspect this lady, who has a short gut syndrome, probably says, well, should I take my acetaminophen oxycodone orally, or should I crush it? I'm a nurse, and I can inject it and get a better kick from it because I'm not absorbent if I got a short gut syndrome. So I started reading about this disease, and it's very well described. It's caused by the IV injection of pulverized pharmaceutical tablets. You can see the other names this has multiple names in the literature. And the tablets typically contain insoluble binding agents such as Staloch, microcrystalline cellulose, crospovidone, potato starch, cornstarch. And if you do a biopsy, you're going to see polarizable material frequently inside the giant cells or the granulomas. And these are some of the common culprits. I'm going to concentrate on the first three. Talc, which is usually present in methadone. This gives you initially causes an arthritis, which is then followed by foreign body formation of granulomas and then fibrosis. And what you see is, and the pathologist will tell you there's birefringent crystals under polarized light. You can have microcrystalline cellulose fragments. And microcrystalline cellulose is commonly used in some narcotics like Vicodin, oxymorphone, and oxycodone. It's similar to talc, but the larger size of the particles makes it less likely to embolize to other organs. Talc you can actually see in the spleen and other organs as very small particles, but this one stays in the lung. And these ones are also positive on a PAS stain, also on a silver stain, as well as a Congo red stain. And finally, there's cospovidone, which is commonly used in many opiates, including Percocet. And this causes a pulmonary angiothrombosis with destruction of the pulmonary artery wall and foreign body cell formation. And you may see some basophils around sort of what is described as a coral-like deposit that resembles calcifications. You can see a couple other things, which are cotton wool fibers, and the cotton wool fibers occur not because they're in the tablets, but after being pulverized, the person then heats the compound and injects it through a cotton wool for sort of like a filter. So you can see cotton wools in there, and they tend to be birefringent. And finally, you can see cornstarch and soluble sugars, and that's usually because somebody's injecting something that they got illegally in the street. So they could come, Vicodin or oxycodone tablets could be crushed and sold in the street, and they tend to be cut with cornstarch or with soluble sugar, so you'll see them in those situations. And again, I don't think that's the case in her. So I suspect we're going to see either microcrystalline cellulose or cospovidone in her lung. And why do I also think this is what's going on? Well, primarily because we have an ongoing opioid epidemic and prescription drug epidemic. And you can see here over the last several years how we're seeing the number of opioid prescriptions have literally quadrupled since 1999. And this has resulted in some states, this has been even higher than that. And this has resulted in an ongoing epidemic of opioids deaths in the U.S., and very related to that also an overdose of heroin, because frequently these people will then get access to very cheap heroin. And if you haven't read a book called Dreamland, I would strongly recommend you read that book because it really talks about this emerging prescription opioid and illegal opioid epidemic. So what do I think is the further workup that is needed in this case? I think I would ask to complete the workup for a PPD or an IGRA. I still think that getting a histo-urine antigen will be useful. Getting an echo will be useful. I'm worried still about the possibility of endocarditis. But I go back to the patient and find out, I didn't know which opioid she was prescribed, but I would like to ask what she was prescribed. And I would confront her directly about saying, I think you're probably crushing it and injecting it. But at the end of the day, I think the issue is tissue, and I think we need a lung biopsy, ideally through VATS at this point. And therefore, I would end here and turn it back to Dustin.
Thank you, Dr. Del Rio. Well, fortunately, most of what you suggested we're about to show you. We agreed tissue may be the issue here, so when we first saw her, we referred her directly to thoracic surgery where she got a VATS and lung biopsy. We did do some other diagnostic tests, like you mentioned. The Aspergillus galactomannan and urine histoplasma antigens were negative. Towards the TTE, when she was bacteremic with Staph aureus, she had got a TTE at that time, which was negative for vegetations, and everything was fine on that. We didn't repeat it at this time. I won't delve into the lung biopsy findings too much at this point, other than to say all of the cultures that were obtained from it came back negative. So at this time, I'm going to bring up Dr. Veera Raghavan, who completed his medicine residency at State University of New York in Brooklyn before going to Los Angeles for his pulmonary and critical care medicine fellowship at the University of Southern California. He joined us here at Emory in 2010 as a faculty member in pulmonary, allergy, critical care, and sleep medicine, where his interests lie in critical care medicine and interstitial lung disease. Dr. V.
Thank you for asking me to talk today. It's a difficult case. I have to tell you that I know the case. But usually when pulmonologists, I don't know, Dr. Guido may disagree, when we come across this kind of difficult case, this is complex, lots of history and all that, the first thing usually a smart pulmonologist does is get an ID consult. We know they go through, they read all the things, they go to the lab, check the cultures, review everything, spend 2 hours, and then tell us what the answer is. he's already done that. So I'm not sure what I'm going to add here, but he gave me 5 minutes or so I got to say something from the not-so-smart pulmonologist who tries to solve it myself. But I do know the case, I got to tell you. All right. So this is just, again, background history, as Dr. Del Rio talked about. Some of the main things is TPN-dependent, so I always think about mechanical and infectious complications related to that. We talked about opioid dependence, whether it's related to that. CT will come to in a minute. And then the main history is shortness of breath on activity, but almost every patient who comes to my clinic says that, so I don't know how much it adds to me. All right. This was a review of symptoms apart from the pulmonary. She has some GI symptoms, which is related to her long-standing underlying problem. There's not much of other things which are very contributory, which may be important in terms of being negative, in terms of being infectious and all the other things. It's, everything is negative. And then the occupation being a retired healthcare worker, it's always important. We all have taken internal medicine boards where, you see that, and then you take surreptitious use of insulin, right? So it may be related something to that. And then of the labs, the only thing which is maybe a little bit positive is the hemoglobin is slightly low. We already talked about the pulmonary function test, so I won't go into great detail, but then you got spirometry, lung volumes, flow volume loop, and diffusion capacity. The spirometry and lung volumes are more or less normal, maybe a slight flow limitation, but nothing dramatic, significant. The flow volume loop also looks all right. Like he talked about, the diffusion capacity, uncorrected for hemoglobin, was moderately low, around 56%. So here's we have normal spirometry, lung volumes, and when you correct for the hemoglobin of 11.2, maybe around 60%. So a mild to moderate reduction in diffusion capacity. So when you have an isolated reduction in diffusion capacity, you always wonder about pulmonary vascular disease, if the patient has pulmonary hypertension or anything else. Sometimes you get early interstitial lung disease. You don't see a whole lot in the lung volumes and spirometry, but you can see changes in diffusion capacity, especially in diseases like sarcoidosis. But we know that the main thing is the impressive thing is the imaging, right? So we already saw the chest X-ray. It's got bilateral, extensive pulmonary nodules. It's all over. There's no clear predilection. Maybe a little bit more on the lower lobes. But then the CT is there. There's extensive bilateral pulmonary nodules. There are a few things I want to tell you in this. One is that most of the nodules looks almost solid. We don't see a whole lot of ground glass, like hazy nodules. A lot of them look pretty similar. They're all what you call micronodular, which is less than a centimeter. And some of the things is, you see that it's not sitting right on the pleura, but there's a little bit of gap between the pleural surfaces. And if you look carefully, which may or may not be able to see in this projection, is some of them are the end of vessels, and you wonder anything to do with the vasculature. So that's the other cut. And then if you look at, so this is what you would call as centrilobular nodules, and we'll come to that in a minute. And Dr. Del Rio has already discussed all these differential diagnoses in terms of centrilobular nodules. You have infection, inflammation, which is like hypersensitivity pneumonitis, pulmonary Langerhans cell histiocytosis, sometimes organizing pneumonia, ABPA, vascular. He talked about vasculitis. Talc was his favorite. And sometimes perilymphatic disease, sarcoidosis, even though it's not classic, can present with these kind of centrilobular nodules. So what are these real centrilobular nodules? So this is what is called the secondary pulmonary lobule. There are two secondary pulmonary lobules here, and this is the unit of the lung, and this is what is repeated thousands of times across the lung. And this is a airway with the associated lobular artery. It ends in there, and the vein is somewhere here, drains. There are lymphatics which are right next to the bronchovascular bundle, and then there are lymphatics around the visceral pleura and along the interlobular septa. So depending on where you have the nodules will give you help or differential diagnosis to finalize what is happening in this patient. So when you superimpose this nodules on a CT scan, and this is what it looks like, right? So you have nodules, which is perilymphatic, which is right next to the fissure and along the pleural surfaces. You can see these nodules, and these would be more associated with lymphatics and something like typical like sarcoidosis. You have random nodules, which is all over, which will be both in the parenchyma and right across the pleural surfaces as well. But this patient has something called central lobular nodules, and they are right in the middle of the secondary pulmonary lobules mostly. Sometimes you see what's called tree in bud, which we didn't see it in this patient, which usually sort of kind of debris and mucus plug, which looks like tree in bud and what you would see in a couple of months on trees, and which will always think about airway related and infection. Whenever you see some haziness, ground glass, you think of, again, inflammatory nodules. When somewhere it's a little more solid like this, and it's a tip of a vessel, and the question is always, is this related to something vasculature, something at the end of the vessels? So your differential diagnosis is now going back and looking at the history, not really typical for a lot of infections, not much exposure. You're able to get rid of most of the inflammatory and infectious stuff, and you look at vascular etiology, what is something. The differential diagnosis then becomes smaller and smaller. She has an indwelling catheter, which raises the risk for all these very high, right? So there's something which is related to the catheter she's injecting, or related, which is contaminant in the TPN, which ends up in there. There are case reports of TPN-related nodules, but it's mostly in pediatrics, and the most I've seen is way early in the 80s. So I would think that the fact that it rarely happens in adults, and considering the fact that not being that much important the last several 2 decades or so, I would think that probably there may be some change in how they manufacture TPN. You're unlikely to get those things nowadays. There's something called a benign metastasizing leiomyoma, which is tumors, which is a benign tumor from the uterus, can go around. Sometimes you see this in women. Very rare lung disease, something to think about. And of course, last thing was, as Dr. Del Rio discussed about, is something excipient lung. She's injecting something through the catheter she has, and then ends up deposited all over. Usually, you would see a little more lower lobe predominance simply because of the vasculature being more, but here is everywhere. But maybe there is some increased nodules on the lower lobes, but that would be again a top of a differential, as Dr. Del Rio already said. So the other thing which pulmonologists do is, like, if the ID is not helping them, then just go send them for a biopsy and get the pathologist to get us an answer. So that's where the answer is probably going to help us, either a transbronchial or a thoracoscopic lung biopsy to get a tissue diagnosis for this. I'm going to end here, and is Gabe Seeker's going to be here? Or?
I think he's on his way.
He's on his way. All right. This is this. We need to wait for him.
So while we wait for Dr. Sika, any questions, any comments that anybody would have on the case at this point? Mm-hmm. So the team is being asked. What do you think? Yeah.
I can share that after.
Okay. Oh, Gabe just walked in.
So I think the burning question on everyone's mind is, what's in the tissue? So let's see. I'm going to bring up Dr. Saika, who completed his MD PhD at Mayo Medical Center, Mayo Medical School in Rochester, before doing residency in anatomic pathology at Weill Cornell. From there, he completed fellowships in thoracic pathology and surgical oncology pathology at Memorial Sloan Kettering, and then joined us here at Emory in the Department of Pathology and Laboratory Medicine, where his clinical interests are in pathology of the lungs, pleuron, and mediastinum. So let's see how Dr. Del Rio did.
Sorry, for some reason I thought it was from 1 to 2. So we got left upper and lower lobe wedge biopsies, and this is just a low power view of the lung biopsy one of the wedges. And this is just to orient you, visceral pleural surface, and these are alveolar spaces. So the parenchyma here, right here, I would say is normal, but you can see these nodularity, these little nodules. And this is, in reference, this is a bronchiole with some, an artery here. So you can see that you have these nodular densities here, and they're full of interstitial. It was interstitial. This is a cytokeratin A1, A3, which highlights the pneumocytes. That's brown stuff, and the nodularity is all interstitial. And you can see there are blood vessels in the middle, so they're mostly perivascular. Higher power shows you, here's a bronchiole. There's no arteriole here, but here's a bronchiole, a vein here. And you can see the alveolar spaces, for the most part, are pretty clear, but the interstitium is packed full of these histiocytes, which I stained and they're CD68 positive. But adjacent to that, you can see this very blue or purple nodule, and then this other one that's more clear. Higher power of this, some would describe this as a coral-like, and you can see this kind of blue purplish material. It's foreign. There's a foreign body giant cell reaction to it, so a multinucleate giant cell reaction. And I think this process has been going on for a while because of the extensive histiocytic infiltrate and some fibrosis that was ongoing, so a little bit of remodeling. And then the other nodule was this clear nodule, which also looked foreign, and closer inspection looks rod-like. And this is just under polarized light, and you can see these rods. So it's a polarizable material, and again, associated with a multinucleate giant cell reaction. And you can see the background histiocytic inflammation associated with it, a lot of foamy macrophages, all in the interstitium. So usually this kind of picture or diagnosis is kind of inflammatory if I don't have any clinical information. So I usually call and see, oh, I see a lot of foreign material. I want to leave it at that. But the clinician said, oh, is it secondary to TPN? And I have to be honest, I hadn't seen a lot of TPN-associated foreign material. And of course, there's a lot of, there's some literature, especially from the journal Parenteral Enteral Nutrition, where they describe bipharyngeal amorphous material in the perivascular spaces. But this was a little weird because they were bipharyngeal and amorphous, but we had something extra, that core-like stuff. And when you dig deeper, there's other literature about patients having who are receiving TPN that also have injected other material in there. So because of that, because of the possible TPN association, which I presume Dr. Delry already got, right? Okay. I had to go back and do some extra testing. So whenever we see foreign material, I first decide whether it's airway centered. Are they inhaling it or are they injecting it? And this is perivascular, so it looked for the most part intravenous. And there are a variety of materials that we can look for. The most common are sometimes talc, microcrystalline cellulose, and cross-provident iodine, and then TPN crystals. So again, there's some overlap, especially with the microcrystalline cellulose and talc. They're both refractile. One is rod-like, and we can do additional testing to do it. Talc doesn't really stain. Microcrystalline cellulose often stains with a silver stain, gray and black. This is a stain that we use also for fungi. And then the cross-protein iodine stains with mucicarmine. And the TPN crystals, which mostly I think are calcium phosphate, you can identify it on special techniques which we don't have available, energy dispersive spectroscopy. When it's only bipharyngeal, it's hard to kind of definitively diagnose this one over the other without this technology. But because we have the coral-like space, so this kind of reminds me of coral, I guess, and it's very very blue. And then when you stain it with mucicarmine, it has a characteristic red staining, so that suggests it's cross-provident iodine. And then the adjacent to it, the polarizable material with the GMS stain, which stained black. And that's the cross-provident iodine, and then the microcrystalline cellulose was rod-like and black-like. So, and here you can see the GMS stain under polarized light. Other findings: this patient has interesting findings. Whenever there's foreign body, IV, anything that's going intravenously, you look at the blood vessels, and you can see here here's the bronchial and this artery, very distorted looking thing, intimal proliferation, fibrotic, like it's been there a long time. Here you can see that there's a reactive endothelitis here, and then the intima layer here is very thickened. This is the smooth muscle layer, outer layer, so she's got some vascular changes. This is a elastic stain which highlights the pulmonary artery, and it's supposed to be very thin with a very small intimal layer here. And you can see her stain. She's got a lot of intimal proliferation. This one's almost fibrotic. There's almost no lumen next to it. And then her venules have changes consistent with thrombosed microthrombi that have been recanalized. You can see there's 2 lumens here. That's abnormal, and there's fibrosis around it. And here is an active one where this is a venule, and there's multiple lumens, and there's foreign material in here, and under polarized light you can see that. So, anyways.
Thank you so much. And that's where, when we saw her in clinic, a lot of our concerns had lied. So she came back to see us after biopsy. In the interval, we were able to get some more collateral history as well from the nutrition team that was caring for her. And then when she followed up with us in clinic, we were able to readdress some questions that maybe weren't answered. And I hope you don't feel we withheld this from you, Dr. Del Rio, but when she did see us back, she finally did admit that she had been crushing up pills and injecting them via her TPN axis. So thank you, everyone. Special thank you to Dr. Dan Hunt and Dr. Longa as well for kind of organizing the CPC and helping us have this experience. Dr. Del Rio, what do you think? Questions, anyone?
Okay, so Annie Massard, like in one of our hospitalists, had a case, and I think she's not in the audience. So we had a patient who had a chest X-ray normal, and then in 5 days, it turned like this. She had shortness of breath, and I think she presented a case in the hospitalist conference with us, which turned out to be almost same case. I don't know if we went for the biopsy or not, because the X-ray and the CT, really it was day and night. So we have seen this case like an acute side. Not from the chronic. Thank you.